In this module, I am going to discuss about yet another important condition, that is nephrotic syndrome in children. First is about definition of nephrotic syndrome. We know that the key feature of nephrotic syndrome is massive proteinuria. We should know what is the definition of massive proteinuria. Remember, the definitions in children are slightly different when compared to adults. In children, what we do is a hourly measurement of protein excretion rather than a 24-hour protein excretion as we do in case of adults. Okay. So what is the definition? It is more than 40 milligram per meter square per hour of protein excretion in the urine, then it is called as significant proteinuria. Okay. Meter square refers to the body surface area. Another definition is urine P-C ratio. What is that? P for protein and C for creatinine. If this ratio is more than 2 mg per milligram, that is 2 mg of protein per milligram of creatinine, then also it is considered as significant or massive proteinuria. Okay. Third is urine dipstick testing, which reveals 3 plus or 4 plus proteinuria. This 3 plus and 4 plus are the grades of proteinuria. More the grade, more severe is the proteinuria, right? Now, this PC ratio and urine dipstick measurement should be done in the first morning sample. That is, when the child wakes up, the first morning sample should be taken for analysis. Please remember, both these urine PC ratio and urine dipstick testing are spot test. Okay, so these are some of the important definitions by which we call massive proteinuria in nephrotic syndrome. The other features of nephrotic syndrome include hypoalbuminemia, obviously because of loss of proteins in the urine, and this hypoalbuminemia is defined as albumin which is less than 3 grams per deciliter. Please remember that this is an update in 2021 guidelines. Previously, we have read that hypoalbuminemia refers to low albumin of less than 2.5, but now the cutoff value for hypoalbuminemia is revised to less than 3 grams per deciliter. Okay. The third important point is edema. Usually in nephrotic syndrome, you have edema all over the body, what is called as generalized edema. Okay. And the final thing which can be noted in most cases of nephrotic syndrome is hyperlipidemia. Please remember, hyperlipidemia is due to increased lipoprotein synthesis by the liver, and this results in increased levels of lipids. It is usually defined by serum cholesterol of levels more than 200 milligram per deciliter. That is what is hyperlipidemia associated with nephrotic syndrome. Now, according to the recent guidelines, if you want to diagnose nephrotic syndrome, the key criteria includes presence of significant proteinuria, plus either of hypoalbuminemia or edema. So any one of this along with proteinuria itself will be sufficient to make a diagnosis of nephrotic syndrome. Please remember, hyperlipidemia is not routinely now considered for diagnosis as per the 2021 guidelines. Having studied about the definition of nephrotic syndrome, next we should know what are the disorders which are associated with nephrotic syndrome. The name of these disorders are derived from the findings on renal biopsy. Okay. The first group of disorder, which is a common group of disorder, is the minimal change disease, which is abbreviated as MCD, right? Minimal change disease. This is the overall most common condition associated with nephrotic syndrome. What is this minimal change we are talking about? This is loss or fusion of or effacement of the food process of the podocytes. We all know that podocytes are the glomerular epithelial cells which contain certain small projections called food process. When there is loss of that food process, that is when we call it as minimal change disease. Basically, remember, due to loss or fusion of food process, there is loss of negative charge. And because of loss of negative charge, there is loss of protein in the urine. This is based on a very simple concept. What is that? Normally, because of the food process, there is negative charge at the level of the podocytes. Now, this results in repulsion of the negatively charged protein. So, they are not usually excreted in the urine. On the other hand, in minimal change disease, because of the loss of food process, there is also a loss of negative charge. This results in no repulsion, or in other words, expulsion of protein in the urine, contributing to proteinuria in this condition. This is the main pathology in minimal change disease. Okay, now other than minimal change disease, some rare conditions are also disorders in nephrotic syndrome, which include significant change disorders. Significant change disorders. Under this category of significant change disorders, some important pathological conditions are there, which include FSGS, that is focal segmental glomerulosclerosis. Second important condition is MN or membranous nephropathy. Okay, and third important condition is MPGN, which is membranoproliferative, that is for M and P, membranoproliferative. GN is for the glomerulonephropathy. These are the three important conditions which are associated with significant change disorders causing nephrotic syndrome. Now, there are certain characteristic differences between this minimal change disease, which I'll write as MCD is an abbreviation, and significant change disorders. First is the age at onset. Minimal change disease generally affects the children in the age range of 2 to 6 years. Whereas for significant change disease, it is in older children, usually more than the age of 10 years. That is, the adolescent age groups are commonly affected here. Okay. Then gender, males are more commonly affected than females in case of minimal change disease, whereas for significant change disease, males and females are equally affected. Third is the incidence of hematuria. Remember, a minimal change disease is a typical type of nephrotic syndrome where there is no associated hematuria, whereas in significant change disease, there is usually association with hematuria. Now remember, hematuria is a characteristic feature of nephritic syndrome. So this type of nephrotic syndrome with presence of hematuria are called as nephritic onset nephrotic syndrome. Okay. Yes. Next is regarding the blood pressure. Minimal change disease, blood pressure is usually normal, whereas significant change disease may have hypertension. Okay, right. Especially the cases of FSGS can have high incidence of hypertension. C3 levels in minimal change disease are usually normal, whereas significant change diseases may have low levels. And this low levels of C3 is associated with MPGN commonly, and that too MPGN type 1 is characteristically associated with low levels of C3. Selectivity of proteinuria, high selectivity in case of minimal change disease. It is low selectivity in case of significant change disorders. Response to steroid, this is the most important criteria. There is an excellent response to steroids. Very important point in case of minimal change disease, whereas significant change disorder, the response is unsatisfactory. And a good number of children with significant change disease, they don't even respond to steroid. Finally is about the prognosis. In general, prognosis is good in case of minimal change disease, but in case of significant change disease, it's a very variable prognosis. Some of the conditions have got a very bad prognosis like FSGS, and in some other condition the prognosis is slightly better. However, always good prognosis noted in minimal change disease. These are the important points of difference between minimal change disease and significant change disorders causing nephrotic syndrome in children. As I said, minimal change disease is characterized by an excellent response to steroid. What is the response defined by? This response is defined by something called remission. Remission refers to a condition wherein the child has responded by decrease in the urine protein excretion to normal levels. And what is that normal urine protein excretion defined by? A value less than 4 milligram per meter square per day, or the urine PC ratio less than 0.2, or the urine dipstick testing shows nil or trace for 3 consecutive early morning urine specimen or first morning urine specimen or urine sample, then we will call it as response or remissions achieved with the steroid. Okay, so very important is 3 consecutive day first morning urine sample have to be analyzed. Then only you can call it as remission. Okay, now let us know about what is the usual treatment schedule with steroids. The commonly used steroid in treatment of nephrotic syndrome is prednisolone. We generally give oral prednisolone. Okay, initially this prednisolone is given as daily medication, and the usual daily dose is 2 milligram per kilogram every day. You can give this as 1 to 2 divided doses. Okay, or you can also calculate the dosage in another way, 60 milligram per meter square. This meter square refers to the body surface area. Please note the maximum daily dose is 60 milligrams per day. Okay, right. So this is the daily treatment which you have to give for 6 weeks. Okay, now after this daily treatment of 6 weeks is over, then we give alternate day steroids. Alternate day steroids is again given for 6 more weeks, and the dose is 1.5 milligrams per kg per day, or if you calculate in body surface area, 40 milligram per meter square per day. And this dose is usually given as a single dose. Okay, usually in the morning time it is given. And for alternate day steroids, the maximum dosage is 40 milligram every day. Okay, so this is how you are going to treat a child with a nephrotic syndrome. Okay, right? Now remember this point, a typical course of nephrotic syndrome is characterized by relapses. Relapse is defined by recurrence of the disease. What is recurrence or relapse? It is defined by, again, urine sample showing more than 40 mg per meter square per hour of urine excretion, protein excretion in the urine, or spot PC ratio more than 2 mg per mg, or the dipstick shows 3 plus or 4 plus for 3 consecutive days, then you call it as a relapse. Okay, please remember, relapse usually occur in most of the children with nephrotic syndrome, and these relapses are usually occurring till second decade. That is a usual rule for minimal change disease. They can have recurrence of disease or relapse till the second decade. Okay, now how are you going to treat relapse in case of nephrotic syndrome? Treatment is again with steroids. You give daily steroids in the same dose, 2 mg per kg per day or 60 mg per meter square per day, till the child achieves remission. And following that, you have to give alternate day steroids also. Again, alternate day steroid refers to the same dosage of 1.5 mg per kg per day or 40 mg per meter square per day. This alternate day steroids have to be given for the next 4 weeks. Okay, so this is also an update in the treatment guidelines according to 2021 guidelines for treatment for management in nephrotic syndrome. So that is about how to go about for treatment of relapses in nephrotic syndrome. Okay, now you should know some terms which are associated with nephrotic syndrome. So till now I have told you about the classical type of nephrotic syndrome, which is minimal change nephrotic syndrome. And I also have told that some children, especially older children, can develop significant forms of nephrotic syndrome. Example is FSGS. You should also know there is one more variety of nephrotic syndrome called as congenital nephrotic syndrome, which is very early onset of nephrotic syndrome. This early onset refers to an onset in a child less than 3 months of age. Okay, right. And this condition includes a group of genetic disorders. That is why when you are evaluating a child with nephrotic syndrome at a very young age of less than 3 months, you should also do, in addition to renal biopsy, gene testing also. So here the commonly asked question is, what are the gene defective and what are the corresponding pathologies in congenital nephrotic syndrome? The 3 important genes that you have to remember. First one is called as NPHS1 gene, which codes for a protein called nephrin. This is inherited as an autosomal recessive condition, and pathology reveals microcystic dilatation, of proximal tubules. That is a pathology in the NPHS1 gene mutations. Second type of gene mutation is NPHS2, which codes for a protein called podocin. This is again autosomal recessive inheritance, and the pathology reveals FSGS, that is focal segmental glomerulosclerosis. Third is a gene defect called WT1 gene defect, which is again an autosomal recessive condition, and this is associated with a condition, with a syndrome called as Dennis-Drash syndrome. Okay, and in this particular condition, there are some important associations in addition to congenital nephrotic syndrome, which include ambiguous genitalia in a male child and increased risk of Wilms tumor. Okay, and if you do the pathology in this particular condition, you will get diffuse mesangial sclerosis. It's not a focal sclerosis, but diffuse mesangial sclerosis. Okay, so these are some of the important conditions which are coming under the category of congenital nephrotic syndrome. Okay, now we are going to discuss about some important terms in nephrotic syndrome and management of those conditions. First is called as a frequently relapsing nephrotic syndrome, which is abbreviated as FRNS, which is frequently relapsing nephrotic syndrome. What is called frequent relapses? It is more than or equal to 2 relapse in the first 6 months, that is after the first episode. In that next 6 months, if the child has more than or equal to 2 episodes, or more than or equal to 3 relapse in any 6-month time period, and third definition is more than or equal to 4 relapses in 1 year. Then it is called as frequently relapsing nephrotic syndrome. Okay, right. Next is called steroid dependent nephrotic syndrome. This is a condition. SD is steroid dependent, NS is a nephrotic syndrome. This refers to a condition wherein child develops 2 or more consecutive relapses while the child is on alternate day steroids or within 14 days of stopping the steroids. Then also it is called as steroid dependent nephrotic syndrome. Okay, right. Now these two definitions are considered together because for both these conditions the management is the same. For frequent relapsing nephrotic syndrome as well as steroid dependent nephrotic syndrome, the management is the same. The management includes administration of alternate day low dose prednisolone at a dose of 0.5 to 0.7 milligram per kg, right? This same dose has to be given daily in case of infections, because it is said that infections can precipitate one more relapse of nephrotic syndrome. So during the time of infection, that is 5 to 7 days of infections, you have to give daily dose of prednisolone. That is the usual management for frequently relapsing nephrotic syndrome and steroid dependent nephrotic syndrome. Suppose while on alternate day low dose prednisolone, the child is able to maintain remission throughout, or what we call as stable remission. Then what we can do is we can decrease the dose of steroid to 0.2 to 0.3 milligram per kg and continue for a period of 6 to 12 months, following which you can stop. Okay, this is the general guideline. However, in spite of giving alternate day low dose prednisolone, the child develops relapse or the steroid requirement or the threshold of steroid becomes more than 0.7 milligram per kilogram, then that is an indication for usage of steroid sparing agents. Now, which steroid sparing agent to use is further decided by certain characteristics, which includes threshold of the steroid. Number 1, that is the dose of steroid to achieve remission, or presence of features of complicated relapse. Okay, first of all, let me explain what is complicated relapse and then we'll come to the further discussion. Complicated relapse refers to a relapse wherein there are life-threatening complications occurring, which includes hypovolemia, which is requiring inpatient care, number one. Okay. Number two, presence of life-threatening infections like peritonitis or cellulitis. At this point, I would want you to remember the most common cause of peritonitis in a patient nephrotic syndrome is Streptococcus pneumoniae. That's an important question often asked in the exam. And third is a patient at the time of relapse having a complication of thrombosis. This thrombosis is basically attributed due to increased production of fibrinogen by the liver, which gets converted into fibrin and forms the thrombus or the clot. Another reason is low levels of anti-clotting proteins like protein C and protein S, which are lost in the urine in nephrotic syndrome. Right? These are the reasons which are said for thrombosis. So coming back to the main topic, that any of this hypovolemia requiring inpatient care, infections or presence of thrombosis, you will call it as complicated relapse. Okay, right. If a patient is having complicated relapse or the threshold is more than 1 milligram per kg per day of prednisolone, if both or any of this, okay, that I will do it again, okay. If any of this is present, okay, then the initial steroid sparing agent of choice is MMF. What is MMF? It is mycophenolate mofetil. Second choice agent would be cyclophosphamide. Okay. That is the guideline. So you can remember MMF as the usual starting agent in case of complicated relapse or threshold more than 1 milligram per kg. If the threshold is less than 1 milligram per kg or there is no evidence of complicated relapse, then the usual starting medication is levamisole. If there is no response to levamisole, then you can use MMF or the mycophenolate mofetil. So remember, in case of non-complicated relapses, the usual starting drug is levamisole. Okay, so this is how you are going to manage patients with frequently relapsing nephrotic syndrome as well as steroid-dependent nephrotic syndrome. Please remember that even though this appears to be a little tough topic, these are the updated 2021 guidelines. So there is every possibility that when a clinical scenario-based question is going to be asked, they may focus on the 2021 or the recent updates in nephrotic syndrome. That's why I want you to know about this topic in detail. The next in the definition of nephrotic syndrome is something called as SRNS, which is steroid resistant nephrotic syndrome. Okay, right. Now please remember, what is the definition of steroid resistance? Obviously, it is no response to steroid even after using daily steroids, that is daily prednisolone at the dose of 2 milligram per kg per day for 6 weeks. Okay, so even after using daily steroid for still 6 weeks, still the patient has no response or no remission, then it is termed as steroid resistant nephrotic syndrome. An important point to note is the duration of 6 weeks, because previously the definitions were like 4 weeks and 8 weeks, but now it is changed to 6 weeks, and this is a potential question in the upcoming exams. Okay, right. Now let us see how to treat a patient with steroid resistant nephrotic syndrome. Here is an important point. Before starting treatment for steroid resistant nephrotic syndrome, renal biopsy is a must, because this will help us to identify the particular condition and also to tell about the prognosis in these disorders. So all cases of steroid-resistant nephrotic syndrome, before you start treatment, you have to do renal biopsy. This is a dictum which you should follow. Now coming to the drugs which can be useful in the management, the commonly used group of drugs in this situation is calcineurin inhibitors. Okay. And we know that the commonly used calcineurin inhibitors are tacrolimus and cyclosporin. Which is the preferred medication? It is tacrolimus. Okay, so I'm writing tacrolimus more than cyclosporin, basically indicating that tacrolimus is the usual medication of choice for steroid-resistant nephrotic syndrome according to the present guidelines. Okay. Now the only point about this tacrolimus is avoided or contraindicated in patients with seizures and in hyperglycemia. So in these two conditions alone, cyclosporin is preferred. Otherwise, in all other scenarios, tacrolimus is the initial calcineurin inhibitor for the treatment of nephrotic syndrome. That is about the guidelines as well as some definitions in nephrotic syndrome. I have included all the relevant facts from the new 2021 guidelines for management of nephrotic syndrome. One last part about the management in nephrotic syndrome includes the timing of administration of vaccines in a child with nephrotic syndrome. If you are using steroids for the treatments and if the child has received more than or equal to 2 milligram per kg per day of steroids for more than or equal to 14 days, okay, which is what we generally give for a typical treatment in nephrotic syndrome. So all patients, you can remember like this, all typical patients in nephrotic syndrome treated with a typical schedule of steroids will come under this category. They should avoid vaccines for 1 month after stopping the steroids. Okay, right. And if you are using cyclophosphamide, if you have used cyclophosphamide, you should avoid vaccine for the next 3 months. Please remember, in all these scenarios, the vaccine I am talking about is a live vaccines. Here also live vaccine, here also the live vaccines. Okay. Now why this is because following administration of these medications, there could be immunosuppression and that would result in the antibody response following the vaccine administration. That is why they have to be avoided for a certain period of time following completion of treatment. Now other than cyclophosphamide, if you use the other agents like mycophenolate, mofetil, as well as levamisole and calcineurin inhibitors, you will avoid live vaccines for next 1 month. Okay, right. This is the timing of administration of vaccines in a child with nephrotic syndrome. And next important point is there are some recommended vaccines in a child with nephrotic syndrome. Please remember, the usual group of infection which occurs in a child with nephrotic syndrome is peritonitis, which is commonly caused by Streptococcus pneumoniae. So it is very, very essential that all children with nephrotic syndrome should receive the pneumococcal vaccine. Okay, right? It is usually administered as pneumococcal conjugate vaccine. 10 valency vaccine is there and 13 valency vaccine is there. Preferred vaccine is the 13 valent pneumococcal conjugate vaccine. Okay, it is usually given after the age of 6 months as a 2-dose schedule, at least 8 weeks apart. This is the recommended schedule for pneumococcal vaccine. Next vaccine is the varicella vaccine, which is a live attenuated vaccine. This vaccine is given after the age of 15 months or starting at 15 months of age, again as a 2-dose schedule, 4 to 8 weeks apart. Third vaccine which is recommended in these children is influenza vaccine, which is an inactivated vaccine recommended for children after the age of 6 months, and this vaccine is usually given on an annual basis. Okay, so these are some of the recommended vaccines in a child with nephrotic syndrome. So that is about the discussion of nephrotic syndrome in children. Now please remember that this is an updated topic according to 2021 guidelines. So from this topic, definitely questions are expected in the upcoming exams, and I want you to remember about the key points in each aspect of nephrotic syndrome, which includes conditions causing nephrotic syndrome and definitions used in nephrotic syndrome. That's about this module of nephrotic syndrome in children.